Our patient is also 57-year-old gentleman. He was admitted this time with sudden onset of dyspnea and chest discomfort for 3 to 4 hours of duration. And if we dig into the past history, he had a very delayed presentation of anterior wall MI in 2017, and after that we evaluated him because he presented with LV dysfunction and all, and had aneurysmal scarred apex, and he was put on medical management. He was a survivor of sudden cardiac arrest, so the ICD implantation was done as there was no other critical lesion at that point in time. The circumflex had 50% lesion in proximal segment. He is a diabetic, hypertensive, mild chronic kidney disease and hypothyroidism. And EKG this time did not show any fresh changes, except there was a poor progression of R wave and intraventricular conduction defects were there. His drops were raised, and of course the NT-proBNP was also significantly raised, and he had severe LV systolic dysfunction. So ejection fraction was 25%. And working diagnosis was that ACS with acute decompensated heart failure. So we first stabilized him with diuretics and inotropes. So I will show you the angiograms. Can you show the angiograms?
CG.
So we're seeing.
So this is what we had on the left side. You could see the LAD was mid-segment 100% occluded, and the circumflex OM bifurcation had critical disease, and probably that was the culprit lesion. And you could see the ICD leads are there. Can we see the right artery, please? So right was not having any significant disease. So since he presented with acute coronary syndrome, had some amount of heart failure, the circumflex and OM was flowing, so we wanted to stabilize him and then treat the circumflex OM bifurcation. We had planned to put, circulatory assist device, either intra-aortic balloon pump or so. But in couple of days, he has stabilized his. You can see that without any inotrope, the blood pressure is in the range of 140. He is lying comfortably. Saturation is 100%. Arterial blood gas analysis was good. So we thought we'll keep the circulatory assist device on standby, and we would tackle the circumflex OM and see how it goes. So what would be the approach from the panelist in this case, who has got a severe LV dysfunction with post ICD presenting with ACS, some compromised kidney function and in heart failure?
So my first question, Dr. Kumar, this is congratulations. This is a challenging case, an everyday case, a relevant case. Is there any mitral regurgitation on echocardiography?
So it had mild mitral regurgitation, so nothing hemodynamically significant.
And QRS is narrow.
And QRS was also not wide, so that is why in initial period CRT was not offered to him. It was just the ICD for sudden cardiac death.
I mean, I think this is totally reasonable. I would have started with a right heart or an EDP assessment, especially with the renal function. I like to keep my right heart in so that I know what the opening wedge is and then what the closing wedge is and any changes in between. You can sometimes the hemodynamics will deteriorate prior to the patient deteriorating for hemodynamic support. I think that having it on standby is totally reasonable. And I think that your main focus here is the large circumflex second OM. But yes, that top OM needs to be preserved.
For the side branch.
And you need to limit the amount of contrast. So we'd love to see what your bifurcation strategy is. But my biggest concern is to make sure that you secure the large branch and keep the first OM open.
Yeah, so that's what we are trying to do. So I have just at this point in time, this is the fluoroscopy. So we have wired the main circumflex and the large OM2 and the OM1. So we are going to dilate the OM1 first, and this is 2 into 15 balloon from Merrill, the
Maybe
mosaic
change it
balloon you
slow.
could see. So please go up 10, 12.
Slow,
So
slow,
we are
slow.
dilating the side branch, not very high pressure. Negative.
Sandeep.
10.
Yeah, so this
So
is,
we'll try to keep it provisional.
yeah, so this is
Negative.
kicked out, yeah.
You can see it's very fibrotic.
Yeah, it's kicking
Yeah.
out your balloon.
Slow
Yeah,
chana.
9, 10.
Slow.
And this is where in the United States, we
Slow.
often will use a specialty balloon
Mm.
Two.
after pre-dilating,
Yeah.
and specifically,
hold.
I have
Yeah,
started
negative.
utilizing the cutting
Mhm.
balloon because it does
9, 10,
take
yeah.
care of these fibrotic
Did-
lesions a little bit better.
Mhm. 12. Yeah, that's right. So we, I think,
pull करके कर दो,
10.
तक.
So now it has holding the place and it's giving way. So you
Slowly,
can
है ना?
see that the waist has gone. So this is fully dilated. So we'll not take frequent checks for the sake of reducing the amount of contrast.
इसे सिर्फ ले ले.
So we'll pre-dilate the main circumflex also at the same time.
Heparin 8 हो गया.
Can we have it on the
So
circumflex?
from our institution, we have done quite a bit of work on what we call zero contrast PCI, where you use, you know, outside of the initial diagnostic, everything is done with imaging, image guidance, and
Yeah.
you know, undoubtedly this OM1, despite your attempt to not dissect it, is going to have some dissection. The question is it flow limiting or
Cell
not,
dissection, yes.
and how do you manage that?
Yeah, that's right. So we'll take a shot when we have done the pre-dilatation for both the arteries. So we'll do a pre-dilatation because here we have got a good landmark. We can, without contrast, we would know that we are across the lesion. So we will dilate at the most tightest point. So can we go on 12, 14, 16? Yeah,
Slip किया.
negative.
Negative.
12, 14, 16.
Slow slow जाना तो hold करेगा.
Negative, please.
फिर नीचे.
12. Good, negative. So as you could see that there is a, though the critical lesion is more focal, but there is a diffuse long plaque going right up to the middle segment of the circumflex.
Anti-cheat.
So we would, like to cover the whole segment.
Yeah, so that was a pre-dilatation
So-
with a 2.5 Mosaic NC or compliant?
Yes, that was with the mosaic NC, yes. So we'll take a check shot that how does it look after the
एक
dilatation.
भी
Can you show the,
नीचे का भी दिखा थोड़ा सा एंगल.
so this is how it looks like. So how many of you would go for a single provisional stenting and how many of you would prefer having a two stent strategy in this case?
So, Dr. Kumar, this is Ramesh. I think this
Entity ortho.
Ramesh,
OM1 is small from my opinion. Okay, now you're
Yes.
using a 7
Yeah,
French
that's what
guide
I
or a
felt
6
like,
French
yes.
Dissect हो
guide?
गया.
Yes, it's a 7, right.
Okay, so I still
It's
it
a
is-
7 French guide.
yeah. So I would still prefer to go with
Yeah, so I think,
a single provisional stent strategy. How about you, Gautam? I mean,
yeah, that's right.
Dr. Kumar, this is Girish from United Kingdom. It's a very complex case and
Yeah, yeah.
well done for taking this patient on a live case. Contrast is an issue here and opacification is also an issue because of the same. What about use of IVUS to size both the branches? If your side branch is less than 2.5 millimeters, you can go with the provisional to minimize contrast and get out.
Yeah, that's right. So in fact, we had planned for the imaging this case, but unfortunately this morning our IVUS is not working. We had OCT, but in this case we wouldn't like to use contrast for OCT. So I think we will have to do it in a minimum contrast OCT at the end of the procedure probably.
So the only other
So I
thing
think we
I
would
say,
take a long,
Yeah, is in the main circumflex lower OM, there's diffuse disease beyond the bifurcation. And my question only would be, are you
Yes.
planning to cover that or you're not planning to cover that?
So I'm planning to use a long stent, maybe a 38 millimeter, so that we cover up to the mid segment, because you could see right up to the
Yeah.
mid segment there is a diffuse disease.
Agreed, yeah, that's what
And
I would
so
do.
it's better to cover with a long stent. Yeah.
Correct, yeah.
So can we have a 338? So we would be using biomime lineage, which is top in the line. If we can have few slides on that biomime lineage.
48
Can we
लेना
have
48 लेना यहाँ आना
38?
48
37, yeah. So we have 337 biomime
छोटा
lineage, which we will be using in this case. As you would know, it's lineage of biomime, and so it has got a new balloon technology on which it is mounted, and its pushability is quite good. So we'll check in slightly tortuous and longish segment here, and some calcific is there. The best part is that it's in the next gen balloon technology, and it has got a monolithic construction, so that helps in pushing. And we will see that it is distal shaft is absolutely monolithic, so balloon is having advanced material, and you can see how after the deployment
2.75.
this stent would look like. So the balloon technology has
Oh,
made
है तो
it really
348 नीचे।
good, so that the trackability is much better, unlike the
2.75
older
में
generation
48
where
है।
there was doubling up of the at the monorails point. That problem has been sorted out completely, so it's as good pushability as in any one of this class stent from any other company. Next.
अच्छा
So this is how this would look like. So you can see that the monolithic balloon
37
technology, especially at the distal end before the
38
stent, looks pretty good. Pushability is really good, and it
48
has got lubricious hydrophilic
2.75,
coating also,
48 or
so that
340?
makes
ये दोनों
things
रखो
easier.
कहीं।
And there is another advantage of extra long tip 7.5 millimeter short shoulders with no overhang that creates ease of passage of this stent.
348 2.75 48
No, so we'll use 37. And so pushability index also, you could see from this slide presentation that it's really as good, even better than Zymes Alpine, which has an FDA approval for CTO and pushable lesions which need more pushability. Next. So, and trackability performance also, you can look at the biomime lineage. The blue bar is top in the range when you compare, and this is the trackability test, bench testing, which is also has supported the same claims. So I think we'll take 3 into 37 millimeter biomime lineage,
not 40
which is a cellulimus coated stent, and then see how it goes. Can we have it?
नीचे वहाँ ना
Yeah. And then we'll do a pot in the proximal segment before the OM branch.
light
And till now, hemodynamically, he is doing good. The blood pressure is still 136/84, despite we have given some intracoronary nitroglycerin
नीचे
and the
हटा देंगे
diltiazem.
कर वो शॉर्ट जिसमें नीचे का दिखा है लगा दो ऊपर
So you can see that the balloon, this stent is tracking, but because the bend, we have to give some support from the guide, and gradually it's slipping in. So we did not want to go too far down, so we would cover up to the healthy segment. So I think we have crossed the lesion, and also we'll do a short check where we'll see whether it is covering the disease segment or not, and then if we are happy with that, we will deploy it.
Yeah, and you could see fluoroscopic calcification beyond the bifurcation as well. So
Yeah,
it's
yeah.
impressive
Yes,
how
yes,
that
yeah.
biomime was able to go with a little push and tug method.
Yeah. So I think those who have used the older biomime, they will see the clear difference with lineage. It's really good trackability, so we have used it, and the performance also, the recent data, which has created a lot of buzz about the Indian stents, they are as good as the any other stent in the world. So can we have a check? Yes. I think the distal edge we are missing, so what we would do is
It looks like
go a little bit down.
Yeah, I would go distal, and then if you need a short proximal, you could always do it.
Yeah. We'll cover the whole distal segment.
I think it's better to use a second stent because even to do a part, you don't have enough stent coverage proximal
Yes.
to the bifurcation. So
Yes, that's
use
right.
this completely beyond
So
the
we'll make sure
bifurcation.
that we are not landing the edge of the stent at the bifurcation point. Can we have a check? Yeah. So that
Thoda
looks
niche.
okay. So we'll go a little bit down just to avoid the overlap at the bifurcation point. Yeah. Yeah, that's good. Go up 12.
Go up, sir. 8, 9, 10.
12.
3
Negative.
touch one. 6
Can
and
we
half.
have a 3.5 into 18?
19.
6 and half
19.
pencil.
So we'll deploy the second stent before taking a check shot.
Yeah, I think your point of not double jailing the bifurcation is critical and staying away from that so that you don't have an overlap segment
Yeah.
anywhere close to that bifurcation.
And this is a stent which has open cells, so let's see how it helps. Yeah, Vinay.
9.
The other thing to consider that even if you do have a suboptimal result in OM1, you can always bail out with a 225 version of this drug-eluting stent
Yeah.
as a bailout TN protrusion technique.
Yes, yes. Yeah, that's what we can do, a tap also. So let's see, we have taken the another 3.5 into 19 millimeter lineage.
Girish, let me
So-
ask you a question about long stents versus short stents in the current DES era. Any data to say that it is better to treat, with OCT now or IVUS guided, we're treating
Boost.
longer lesions or using longer stents?
The average length of
Yeah,
the stents
covered.
that we use or the lesions we use is growing longer.
Check shot.
Single longer
Yeah.
stents, especially with various technologies starting from 48 millimeters going up to
10.
60 millimeters with the Merrill morph stents. The early results are encouraging.
12.
OCT shows better healing. I think the
Okay,
way
negative.
to go forward is to use longer stents than using multiple shorter stents. I could see that's the future.
Overlap करा दो. Overlap.
I also supported that idea. Particularly in that case, I would personally probably would escape to dilate side branch in the
Okay.
beginning. And actually, it's depending how we estimate that's importance of side branch. If it's important, maybe if I dilate, I would continue with decay crash and stenting side
ACT.
branch. But in that case, I would personally first secure main branch and wait for result and check the side branch and still keep the provisional till the end procedure.
दिखाना.
So you could see that the side branch is
wire
also
और दे दे.
flowing,
एक wire और
and
दे दो. Side
the
branch
whole
के लिए.
segment in the disease circumflex artery is well covered. And we'll do first pot and then try to see how the side branch is looking without wire. So can we have a 3.5 into 6 for the pot?
8, sir, we have.
8, yeah, you can give 8. So we'll using mosaic NC balloon for pot.
So costume से अच्छा नहीं लग रहा.
So Dr. Martin, do you
We'll
feel
give
that you
some
would have gone for
nitroglycerin.
two stent technique?
It was a good decision to use the biomine long stent for this purpose because the vessel was clear tapered, the proximal lumen was higher much more, and the proximal part of the coronary artery was
Mosaic
not
NC?
kinking, so the long stent was a good choice. It was by mistake, it was not long enough, but good idea. I will go the same way.
Dr. Kumar,
So
at
we'll do
some
a pot
point-
with the shorter balloon and
Dr. Kumar, after the pot, we can give some nitrates and see whether the side
yes,
branch
yes,
is
yeah,
growing.
absolutely.
That's fine.
So we have given some nitrate and
Stent boost.
boost. We'll use the boost technology for the pot. 6,
Yeah,
8.
we have a lot of decrement in,
बाहर है सर हाँ
ठीक।
ब्लॉक है
हाँ
Ah,
go up 6
8, 9,
9
10, 12.
10
Negative. We'll do the whole stent because it's a long stent. It's better to dilate the whole one.
sure, yeah.
So can we have the 3 into 8? Boost here.
Is it 3.5 or 3.0?
no straight
3
No,
5
so we have done the 3, 5. We'll go with the 3 in the distal segment.
Okay.
18. Just give me a 3 into 12.
3 into
Pot
8
is a
12.
3.8
12,
NC
13.
at high pressures.
NC
Yeah.
that is why
We have the Mosaic line is in the US as well. It's a nice version of
ये हटा दो
Yeah. Mhm.
lengths and
Mhm.
geometries. A lot of long lengths that we don't have.
Yes.
Mosaic makes.
Mm-hmm. So this is 3 into
15 mm
15 m. So we'll do the dilatation of the long stents all through its length, because as you would know, the expansion in long stents may not be adequate enough with the balloon, stent balloon alone. So we should always try to dilate the longer stents, do a post dilatation. So this is a mosaic balloon. So we'll go 12, 14,
नीचे से शुरू कर
14, 16, 18. In the mid segment, the most disease segment. Yeah, negative.
पैरों के ऊपर मत जाओ
Stent boost.
big
एंगल
Either just show the lowermost point.
कॉलिमेट कर लो
Yeah. 1 millimeter back. 9, 10, 11, 12, 14, 16. Negative.
I really think in these cases,
14,
the
16.
post-dilatation with a non-compliant one-to-one balloon is absolutely essential.
Mm-hmm.
Be careful not to be outside
Yeah.
the stent
Negative.
and doing it universally
Mhm.
all the time. Without
14,
imaging, you'd be
16.
impressed how underexpanded we are without MC balloons.
Negative. Yeah, that's very true. 14, 16. 18. Negative.
ओवरलैप कर हाँ
18, 20. Negative.
एक वायर और ले लो साइड ब्रांच कर लो
So I'd like to know from the panel,
So we'll
if-
take a.
when do you decide to do final kissing balloons of this OM1? And how do you decide that?
And did you
As my co-panel member was suggesting, we started dilating the side branch. We actually
Overlap.
injured a little bit of the side branch origin. I think for me, it's going to be the size. If it is less than 2.5, if there is a reduced blood flow with ECG changes, then we probably have to recross and think of a double stent strategy here. However, if the flow is reasonable, there is not much ECG changes, the vessel is looking smaller, probably will run to the hilt at the point.
you want to
Okay.
check
So the flow is okay. And so how many of you would like to recross the OM and try to do just a dilatation?
So how many in
I
the
don't think
audience
this
wanna
deserves a
recross the
stent,
OM?
but the
Raise your
flow is
hand.
good.
Okay,
why
we have a few people. How many want to leave this alone and say we're done? Okay, that's the majority. Okay. How about on the panel? Leave this alone and done?
Can I share my personal experience from the last week? It was about the similar case in this point. It happened, it was a LAD diagonal branch. It was about the same situation, and the jailed wire in the diagonal branch was jailed so much I was not able to withdraw it. After this experience, I would never go for post-dilation of non-compliant bion to the proximal part of the stent before I withdraw the jailed wire.
NTC.
because it happened and it was really bad. So I made a lot of attempts to get it out. It was impossible. After all, the guiding catheter jumped into the vessel, deeply touching the stent, and then the wire was cut and it left in the vessel. The patient became unstable and it finished by bypass surgery. So it's just my experience. I would never post-dilate proximal part of the stent before I withdraw the jailed wire.
So though the recommendation is actually do the pot first from the European Bifurcation Club, keep the jail wire, do pot, and then rewire with another extra wire or third wire if need be. But that said, you're right. I mean, we do come across certain situations where, in my experience, it has only been when there is a stent that has been placed in the past, and now you're jailing between two stent struts. That's when a wire can get stuck. Unfortunately, it does happen. When it, luckily for me, it never happened. But if it does happen, you can advance a small 1.5 balloon or 1.25 balloon over that wire and try to pull it out, go behind the stent strut and try to bring it back. And I think people are jailing not only wire nowadays, they're jailing balloons, jail balloon technique to actually overcome that in case if there's a fracture of the wire. But the risk of fracture is always there, but it is very low.
Yeah, I mean, you got unlucky, but I think.
Yeah, that's right, Ramesh.
Without pulling, I would have taken a balloon down, done that before pulling the wire and severing it. Anyway, Dr. Kumar, sorry,
So-
we're back to you.
Yes, I think that's a very good. Sometimes one can get the jailed wire really jailed and doesn't want to come out. So in that situation, as Ramesh has said, what we tried when there is a difficulty in pulling out the wire, we keep a balloon in the main vessel first, and then a very small balloon, 1.25 or something like that, 1.5, we can slide it from the side of the stent, and then you can pull it out. You can easily pull it out in most of the situations, and then you can do a post-dilatation again to restore the position of the stent deployed in the proximal segment, proximal to the side branch. So I think it's something which has to be identified quite early, and that you can find it out when you're trying to pull the wire out and it's sucking the guide in. But in this case, let me tell you, we did not have any difficulty in pulling out the wire, and we have pulled it out. So how many of you, this current creatinine is 2, and we have got only one imaging modalities, that is OCT, would like to get the OCT pictures, which will work as a final picture for the contrast as well? Or should we just pull it out and take a plain shot?
I mean,
What is the panel's opinion?
So I'll tell you my opinion. There's some Egyptian colleagues, and so I'll tell that with the stent boost, there's an Egyptian paper which looked at the stent boost QCA, IVUS QCA did not make a huge difference. And so both of them are better than angiography alone. So if you have a good stent boost and you can get a QCA, if the stent is well expanded, I would leave it alone in this person because of his creatinine. Obviously, if the creatinine is 1,
Absolutely
we don't have any
so.
discussion. How about
Absolutely.
the panelists?
So we have the creatinine today creatinine is 2, and to begin it, the reason why we had made it a staged procedure was that at the time of admission it was 2.6, eGFR is around 37. So I thought we have used the stent boost for post dilatation and to assess the stent expansion adequately. So I would personally not like to do OCT in this case. However, there are various options of using diluted contrast and so on and so forth, and using the last shot for OCT plus final angiogram as well. But I would like to stop at this because we are very much sure that the stents are expanded. In fact, in the proximal segment, you could see there is a slight overexpansion of the stent. So overall, the side branch, the OM, which is small, is still flowing. The reason why we did pre-dilatation was that a severely ostial narrowing with some amount of calcification. You could see that there was, melon seeding of then when we were pre-dilating. So I think that was the reason to pre-dilate. Otherwise, usually in bifurcations, we don't pre-dilate unless the ostium is really, really badly diseased and calcific. So I think this would be considered as the provisional stenting in a very sick patient who had multiple comorbidities, and I would say that we will not do anything further and stop at this point in time. So what is the consensus among the panelists and the chairpersons?
The panelists, do you want to end here or continue?
I think you got a very good result, Dr. Kumar. I think we should stop.
Yes. How about you, Doctor?
Yeah.
I agree also. The main vessel looks very nice and side branch is still preserved. I'll also stop on that point.
Right, no shot.
Yeah. We all like
So this
to
is the
see
final
OCT
shot.
pictures, but appropriately.
Yeah. Thanks.
so-
Yeah.
I don't like this margin.
Yeah. So I think
I would
if you
like
look at the approach, so
continue and to try to improve it.
You would like to improve the flow in the OM1?
Yes, because it's not the vessel we can sacrifice. I would go. Yes.
I mean,
I'm not sure it's necessary to put a stent into it, but it's a small vessel in circumflex territory, and good POBA results could be about the same prognosis compared to the stent. So I would go for rewiring and try to improve the proximal part of marginal.
No, but given the patient's creatinine is 2, I think majority of us were saying that probably stop here. You have at least a TIMI 2.5 flow in the OM1. It is a small vessel, and all our, whether it is European or Asian bifurcation clubs do recommend not to proceed further at this point of time. So we would recommend you to stop, Dr. Kumar. Thank you very much. I think it's really a great
Thank you very much. Thank you
demonstration.
and we thank all of you from Max.
Thank you from on behalf of Merrill for showing such
Thank
a
you.
wonderful case, Dr. Kumar. Thank you.
Thank you. Thank you. Thanks once again to Merrill and all of you being there.